Hello, everyone, and welcome to the seventh webinar in our ACCRF patient webinar series, Tumor Board for Metastatic ACC. We're so excited to have you with us today. I'm Reed Moats. I'm the Communications and Development Officer here at ACCRF, and I'm joined today by ACCRF co-founder and Executive Director Jeffrey Kaufman, ACCRF co-founder and Director Marnie Kaufman, and our Director of Research, Dr. Nikki Sparty-Burr. On behalf of everyone at ACCRF, we're so happy to have all of you here for what is sure to be an informative and an insightful presentation. Before we get started, I'll provide some background. Next slide, please. I'll provide a little bit of background about ACCRF and today's presentation, and then I'll introduce our panelists who are going to lead us through the tumor board discussion. And then finally, we'll hear some closing remarks from Dr. Nikki Sparty-Burr, who will also provide some information on how you can best stay connected and informed with ACCRF. Next slide, please. So just a few housekeeping items as we get started. So during today's discussion, we will be monitoring the chat for your questions, and we will try to address as many of those questions as possible with our panelists as time allows. So if you do have a question that comes up, feel free to just put it directly in the chat. And we do take patient privacy and confidentiality very seriously here. So please do not provide any personal or medical information in the chat, and please do not publicly disseminate any information from the chat that you may read today. We also do want to make clear that this webinar and the information that is provided today does not constitute medical advice in any way. ACCRF does seek to educate patients so that they can be better equipped to discuss treatment decisions with an experienced physician in a private setting. And finally, this webinar is being recorded and will be sent out via email and posted on our website, along with all of our previous webinars in our patient webinar archive. So look out for an email in the next few days that will have a link so you can watch that again online if you'd like. Next slide, please. So now to provide a brief background on ACCRF. So we were founded in 2005 by Jeff and Marnie Kaufman after Marnie was diagnosed with ACC. And Jeff and Marnie quickly found out that there was very little reliable information on research and treatments available for the disease. So they created the foundation with a mission to accelerate the development of improved therapies and a cure for ACC. And that continues to be the driving force of our foundation almost 20 years later. Our leadership is comprised of both members of the patient community alongside some of the world-leading oncologists who help to steer our research agenda. We have an incredibly dedicated and passionate network of individuals who understand firsthand the urgency of the work we do and who can help guide that work from a patient treatment-centered point of view. And our strategy continues to be the development of a pipeline of clinical trials based on the best available science that demonstrates benefits for patients. Again, we are very, very dedicated and focused on getting the best possible treatments for patients through our research. And over the past 20 years, we have used those efforts to transform ACC from a sort of under-researched niche to a robust field of cancer research that has been led by some of the world's top oncologists. So we're very proud of the efforts of our research and patient network, and we have a lot of hope for the future because of the many new discoveries and breakthroughs that our research community is making today. Next slide, please. Now, just a few thoughts before we start our discussion today. This webinar is going to be focusing on treatments for advanced ACC, and those treatments are some which many patients may never need. So we always advise that you don't assume the worst based on what you may hear. Because ACC is so rare, every patient journey is going to be unique. And so whether you're newly diagnosed or in a period of watchful waiting, it's really best that you focused on dealing with the specifics of your current situation with a trusted physician and not kind of worry about what may be, but really focus on the task at hand in your treatment journey. Because this webinar is, as all of our webinars are, first and foremost about education and about hope. And at ACCRF, we believe that hope comes from having the best information possible to guide you through your treatment journey so that you and your physician or your healthcare providers can really be making the most well-informed decisions for your treatment journey. Next slide, please. So finally, what is a tumor board? So today's webinar is structured like a tumor board to provide all of you some insights into how a tumor board functions, but what exactly is a tumor board? So a tumor board is a treatment planning process in which a group of cancer doctors and other healthcare specialists meet to review new and complex cancer cases with the goal of deciding as a group the best treatment plan for a given patient. So these meetings often include specialists from a wide array of healthcare specialties. For the sake of time and concision today, we're omitting some of those specialists that might normally participate, but we want to give you better insight and ideas about how those specialists kind of interact and are thinking and talking during tumor board review. And so without further ado, I'm going to turn things over to our Director of Research, Dr. Nikki Sparty-Burr, who will introduce our panelists and will help moderate today's discussion. Nikki?
Hi, everyone, and welcome. I'm so pleased to be joined today by Dr. Jonathan Schoenfeld, who is a head and neck radiation oncologist at the Dana-Farber Cancer Institute and Brigham and Women's Hospital, as well as ACC medical oncologist, Dr. Paul Swiecicki, who's from the University of Michigan Medical School. So now we're going to move into the phase of the webinar where we're going to go through a series of ACC cases. They're de-identified cases. And these two physicians are going to chat through some treatment strategies. Again, you can enter questions into the chat and we'll be monitoring those, and so we can relay those to the physicians. Dr. Schoenfeld, please start sharing your slides.
Thank you. It's really a privilege to be here this morning. Thank you for the invitation. And I will bring up my slides. So in a normal tumor board, we would have a number of cases to discuss. And typically the discussion starts with one of the members of the team presenting a case. And so I will present the first case, and then we'll have some discussion as we would in a real tumor board. And so this case begins back in 2004, at which point in time the patient who came to us for care was 32 years old. And this woman developed a cribriform type adenoid cystic carcinoma that originated in the right maxillary sinus. Now, the focus of this patient's original treatment is not the topic of this tumor board, but she originally was treated with surgery followed by radiation, so a pretty typical initial treatment course, and then was seen regularly in follow-up until more recently, when in 2021, she had a surveillance CAT scan of the chest, so a CT or CAT scan of the chest, which demonstrated new bilateral lung nodules. So lung nodules on both sides of the lungs, approximately 3 to 4, as determined by our radiologist. The largest was 2.1 centimeters within the left upper lobe of the lung. And on the right, you can see the patient went on to have a PET CT, and this is the PET CT. PET CT shows activity, or what we call avidity, within normal tissues, such as the heart, that are metabolically active, such as the heart muscle, but also within tumors. And so this here in the lung, and this is the left lung, is a 2 centimeter cavitary left upper lobe lung nodule corresponding to the abnormality that was seen on the CT imaging. And this is kind of a view from the front, so looking at the patient scan kind of head on. And this patient went on to have a CT guided, so using the CAT scan as guidance, to do a biopsy of this left upper lung nodule. And when the pathologist looked at this biopsy tissue, it confirmed that the lung nodule that was seen was recurrent metastatic adenoid cystic carcinoma. So, normally during a tumor board at multiple points when we're thinking about decisions, we would stop and have a discussion about, management or what we think of scans and the treatment course. And so maybe at this point I'll stop and we'll have a little bit of a discussion. The first question that comes up in management is, what should we do for surveillance? And that means after a patient is treated, in this case, it was surgery and radiation back in 2004. What is the best way to follow these patients? And subsequently, when this patient developed a nodule, what defines a suspicious nodule? So maybe I'll ask Paul to comment first on what his practice is, and then I'll comment also.
Yeah, boy, it's a fantastic question. Once again, thank you for hosting. Surveillance is difficult. Typically, most cancers, breast cancer, colon cancer, we think 5 years, and your risk of recurrence is very low. What we've seen for adenoid cysts, it's extremely variable, shown by this case in 2004, the original case, and now 2021, and finally recurring. ACCRF has been funding some research, both at our institution and others, to look at how often we should be screening people and for how long. And I think that will be very useful. Overall, this is for some time, because recurrences can happen 20, 30, even 40 years later. In general, our practice at University of Michigan has been yearly CT scans. And if there's something suspicious, follow up with a little bit closer interval scans every 6 months. Hopefully, with research between different adenoid cystic sites, we can have a more precision type surveillance strategy. In terms of when and how to biopsy, that's a multidisciplinary discussion between ourselves, the thoracic surgeons, the radiation oncologists, and the radiologists. Normally, we look for it to be growing over time. And once again, it changes from case to case. It's very hard to define. Often we wait for it to get at least to about a centimeter. And then if there's only one lesion, we actually may do a surgery to remove it. Once again, we defer to our thoracic surgeons. If there's several spots in both lungs, then we might just do a CT-guided biopsy, as shown here. The reason of the difference is if there's a single spot, we remove it with a surgery, we're done with it. There's no other spots to deal with. However, if there's multiple spots, then we can just biopsy with a needle. Then it brings up the question of how do we address it appropriately. I think that's what Dr. Schoenfeld is about to discuss. But I'm curious, what about at Brigham? What's your practice?
Yeah, it's pretty similar. I mean, I think we admittedly wish we had more kind of data. So it's very helpful to continue to do research to really see what the best way is to follow patients. But I completely agree. I mean, we treat this differently than other types of head and neck cancers, other types of cancers that we see, and that we typically don't think there is an interval after which we stop doing surveillance. So, in other types of cancers, we might stop after 3 years or 5 years. In patients with ACC, we typically would do maybe some more frequent scans the first few years after initial treatment, and then, enter what we call kind of longer term follow-up, where we typically would still, kind of do imaging about once a year in most cases. But that's also a discussion with patients because, we admit we don't have the data to really guide us about the frequency of scans or what types of scans we want to do. So usually we will do a CAT scan of the chest, and we'd recommend a CAT scan of the chest once a year.
I think that gets you a great. Oh, apologize.
Sorry,
please.
just a quick follow-up. Should every scan also include the abdomen to view the liver? And how do you recommend that?
So we typically don't. I think that's a good question. And that gets back to the fact that we can't, no scan is perfect, and no scan is going to catch, kind of everything. And scans also have what we call false positives. If you scan people that have no cancer with a history of cancer, without a history of cancer, you will get, abnormalities that turn out to be just scar tissue or evidence of a prior infection or things completely unrelated. So we always are balancing kind of the risks and benefits of doing scans. And that is, how frequently we do scans, but also what types of scans to do. And for ACC, we usually just focus on the lungs or the site in the head and neck that was originally treated, because we think, at least according to the data that we have, for most patients, those are going to be the areas of most risk. But what do you think, Paul?
I think that hits a couple very important points. For one, our technology is getting better over time. And one thing that we run into an issue with is technology gets better, that sometimes presents new diagnostic challenges because now we see things smaller and smaller and smaller. And after you've had a viral infection, or even after you've been a beautiful fall day, you actually develop pulmonary nodules, which are very, very common. And now we can see very, sub-centimeter, 3-4 millimeter spots, and that's completely benign. However, of course, in cancer, we always get concerned. And so that's why it's so important. I think in the coming slides, we're going to discuss how do we follow this over time. I think the other question I hear very frequently is, well, why CT? Why not PET scan? It's beautiful colors. Why can't we do that? CT, and what I tell all my patients, is actually much more high definition. You can see spots in much better anatomic resolution. I always give the analogy of a 1990s TV and watching football, being in Ann Arbor here, versus a high definition TV of today where you can see sweat rolling down people's faces. You can see very, very small spots on CAT scans and follow it over time. And so in general, our practice has actually been to favor CTs when at all possible. There's some contraindications there. And finally, the question about liver metastases, it's a great topic, but in general, if you look at the statistics, when people develop metastases outside of the lungs, for example, liver, the bones, the right leg, most of those people have lung metastases. And so we would have caught it if we're just scanning the chest and avoiding unnecessary radiation.
Yeah. And I will just add that if we do see something, in the chest, like what was seen in this case, then we will go on to do more imaging. So then we would do either a PET scan or a CAT scan, for high resolution. And we typically would do, the entire body or, kind of restage patients at that point. And so I think here we talked about, surveillance. We talked about suspicious nodules. Again, we would always discuss with our radiologists and tumor board and with our surgeons about how best to biopsy it. And often we would do, as we did in this case, a CT or CAT scan guided biopsy. So maybe I'll go on in the interest of time. And so, in this case, getting to the management options, we had a biopsy that showed, recurrent ACC. And so at this point, we think about various management options. And then, in terms of the general options that we always consider is one, not every cancer, not every ACC that spreads to the lung, especially with very small metastases, needs treatment. And we'll talk more about that. So one option that we always think about is, just watch it and watch it closely. The other option we think about is systemic therapy. So that would be, Paul's area of expertise and he'll talk more about it in a minute. And then finally would be local treatment would be, should we treat just the lesions that we see? And within local treatment is a kind of some nested questions. How many? So in this patient, there were a few lesions that were seen that we think were suspicious. Do we treat all of the lesions or do we treat some of them? And what type of local treatment should we pursue? So should we do, surgery? Should we do what we call ablation? And there's several different types of ablation, such as cryoablation using, cold thermal energy to kind of ablate the tumor, radio frequency ablation, or my specialty, which is to do therapeutic radiation. And often we think about a very focused type of radiation called stereotactic body radiotherapy, otherwise known as SBRT for short, as an acronym. So, I think there's a lot of considerations. How would this discussion typically go at University of Michigan, Paul?
Yeah. It's a great multidisciplinary case here, and I always, really depend on the expertise of my head and neck radiation oncologist. I think this is very important to engage people that specialize in this type of cancer. In this case, we would follow up the patient with probably scans at approximately 6 months to judge the pace of disease and understand really how this is growing, because it looks like the original case was 2004. Now we're seeing lesions in 2021. The largest was 2.1 centimeters. And to really assess, is that disease velocity increasing rapidly, or it doesn't sound like they're symptomatic? And based on that change in disease, if they're stable, if they're growing, then we would consider radiation to all of them, given the limited number, versus active surveillance.
Great. And so I think, one of the things I wanted to highlight just in terms of those different options is that there is a lot of uncertainty. And I think, when we talk about the case, this type of case, all of those issues that Paul brought up, do we monitor, how stable have the lesions been? We really, I think, as a field, don't know the right answer in many cases. And so it's a very individualized discussion about, what we think, where the nodules are located, how easy are they to treat, what's the risk, what are the side effects that are associated with each of the treatment, what's the best treatment. But more broadly, is conceptually a question that I think we all struggle with in the field, which is, how aggressive, what should our general philosophy be? In that context, I wanted to mention that a trial that we have started at the, Brigham and Women's Hospital, Dana-Farber, which is the SOLAR trial. And as I'll talk about in a minute, we found that the early treatment of oligometastases may improve outcomes in patients we had treated over the last few decades. And so what does that mean? I think historically, we've kind of divided cancer patients into two kind of groups. So people that have what we call localized cancer and patients that have metastatic cancer that's spread to other parts of the body. But that we're learning over time that probably in many cases, as we learn more about the biology, as our ways of following patients get more sophisticated, that there's kind of this intermediate group. And oligo means that these patients may just have a few kind of areas. And so, there's a thought that maybe treating these few areas aggressive locally might be beneficial. But we don't know that. And what we always like to do is, not just look back at our outcomes over, historically, but also just actually test the question by doing a randomized trial of early radiation of metastases versus, observation. And so, this follows on a number of other trials that have been done kind of in the United States and other countries for patients with this type of condition, oligometastases. And they've really had mixed results. You might have strong feelings one way or the other, and we certainly see patients and doctors that feel strongly, like, of course, if you see, a few cancer spots, why wouldn't you treat them? And then, another school of thought is, well, what are you really doing to benefit the patient if there's still a risk that the cancer comes back somewhere else? And so I think it really depends on the situation. And you can see that by results of other trials. So there was a trial called the SABR-COMET trial, and that was multiple different types of cancers, including some salivary cancers. And there, treating these oligometastases actually seemed to improve survival. Similarly, in patients with prostate cancer, there's been a couple of trials. So all these trials have, they try to get good acronyms for the trials. So STAMP and ORIOL were the names of the two of these other trials. And there was a benefit in prostate cancer, for localized treatment. But in contrast, just to show that it can be different from one cancer to another, just recently we've had, results from two trials that were done on what we call a cooperative group, so within the United States. And that was the NRG is the name of the cooperative group. And so there was a lung cancer trial that was negative. It showed that, treating these oligometastases with radiation or localized treatment didn't benefit patients overall. And similarly, for patients with breast cancer, there was a recent, report of a trial that was negative. So
I don't know about you, but I always find it difficult to interpret these because there's a little bit of patient selection that goes into these. And it's always judging each cancer is completely different, especially in adenoid cystic. And sometimes it's, the patients may be deriving benefit, as we've kind of implied, are those that are growing slowly over time or very stable versus those are, tripling over size, developing new lesions within the matter of a couple months. And it's parsing out which group of patients, which disease biology may be deriving a benefit of oligomet. And so as you're putting it here, I think that it's your prospective study will be so important to address that about who can we really address in that early setting and how do we really pre-screen them with scans a couple months apart to figure out what that best therapy is.
Yeah, no, it's a great point. It's really comes in. Those are the discussions, right, we have in tumor board all the time. It's like, what are the patient factors, and that really kind of drive us to think one way or the other. Here's the data that I mentioned. This is what we call retrospective data. So it's not a trial. We just looked back at the patients that we treated over many years. And this was research that was supported by the ACCRF, where we looked back and saw, how many of our ACC patients, had oligometastatic versus polymetastatic disease, and so might be eligible for kind of this type of approach. And we saw that, especially with our way of monitoring patients, we did see patients with just a few, lung metastases or other metastases. And that when we looked back, it was some suggestion that maybe patients did better with earlier treatment. Now, I will say that there's a lot of caveats, because again, what Paul just said, goes into this data, that we do our best. We don't just, this wasn't randomized. We selected the patients, for local treatment based on, maybe some favorable factors, and that might have contributed to this. But at least it makes us think that it's a question that's worth testing. And so this is the trial. This is the SOLAR trial. This is what we call a trial schema, where we have, I won't go through all the details of the trial, but basically we take patients that come to us, and we say, we don't know what the best option is. So, we are going to follow you closely and either monitor things closely or, be more aggressive and treat with radiation, SBRT, or other types of local therapy. And then really look to see over time, is there a benefit in how quickly the cancer progresses, in your quality of life, in the toxicities, and how well do our treatments work? And so that's the goal of this ongoing trial. So to go back to this first case, so this patient had we discussed all the issues, and we decided, because they had that one larger lesion, to go ahead with surgery. And so the patient had a left upper lobe lung resection, which showed a 2-centimeter lesion of adenoid cystic carcinoma involving the inked pleural surface, but not at the resection margins. And I will just say that, it is a good question. So everybody, of course, feels reassured that the cancer comes out, but there are downsides, obviously, to any procedure. And so, one of the side effects of surgery is that this patient had significant postoperative pain. And then, we're still left with the question of what to do about the other lung metastasis. And so, getting back to Paul's points that he was making before, here are the other lesions that we saw. One was small and was close to the liver. Another one was very small. You can see here in the right lung. You can see that it's just a little bit of a dot here that's not present on the other side. And so actually, for this case, when we then, gave advice to this patient after discussing it in our tumor board, just like, Paul was commenting, we thought, given the long interval between the initial presentation and metastases, the low overall tumor burden, and the trickier location to treat because it was closer to the liver, we decided to observe. And just to highlight, as Paul mentioned, there are data that suggest that certain factors, such as the long interval from initial diagnosis, predict more slow growth. And this patient has fortunately gone on to have stability of these other small lesions for approximately 2 years, which brings us to the current time. So I think that was the end of the first case. Do you have any final comments, Paul, on this case?
No, not at all. It's a great case to cover some very important points and some important trials.
Thank
Dr.
you.
Schoenfeld, can I just ask one question that we saw in the chat that relates
Sure.
to this last point about the interval between initial presentation and metastases? Is there generally a break point at which you say, oh, this is a case where it's clearly less aggressive versus perhaps more aggressive?
That's a great question. I don't think we know what that cutoff is. I think, again, it depends on a number of factors. The way we typically think about it is like we were saying, for other types of cancers, we use that kind of roughly 3-year time point, or even like a shorter time span where these cancers would grow. And if they've grown certainly within the first year, but within the first, couple years, we do think about treating more broadly, but clearly when there's been, decades or more than 5 years, then we think that we hope that even if there's cancer growing somewhere else, it's more, indolent, slow growing. Okay. So I'll go ahead, and then the second case, brings up some of the same issues, a little bit different. This was a 61-year-old man who was diagnosed with a 6.8 centimeter ACC of the right maxilla in 2021, underwent surgery, and then developed 4 lung nodules in late 2023. So 4 lung lesions, 1.3 centimeter subpleural nodule in the left lower lobe, biopsy confirmed adenoid cystic carcinoma, and then 3 additional what we call sub-centimeter nodules, 2 in the left lower lobe and then 1 in the right upper lobe. And so here are the scans that we would, review in our tumor board. And you can see this 1.2 centimeter left lower lobe, what we call paravertebral. So it's next to the vertebral body lesion. You can see this other nodule here in the left lower lobe, looking kind of face on. You can see this nodule here in the left lobe of the lung. And here you can see, this peripheral, so kind of this smaller lung lesion kind of here and here, as I had mentioned. And then a very small lesion that's very, it's hard to even see, but this tinier lesion right here, left lower lobe. And then the right upper lobe, again, you can see a small lesion here in the right upper lobe. So we would go through these in our tumor board with our radiologists and discuss. And so here we decided on a little bit of a different approach. Again, it was a shorter interval. These areas are more tricky to remove for surgery. There's fewer nodules. And we're a little bit worried that this nodule here close to the vertebral body might eventually start to cause pain because it's close to the chest wall. And so we actually discussed the protocol with this patient. This patient enrolled in our SOLAR protocol, and we did radiation to the 2 largest lesions that we saw in the left lower lobe. And here's what we call a radiation isodose curve or heat map. And it just shows where the radiation goes. The colors are what radiation dose, and you can see how targeted we try to be with our radiation, giving the highest dose, right around the tumor, and a much lower dose to the normal lung tissue and to the heart and to other tissues in the body. And again, we did this on protocol, but we also discussed, in our tumor board, whether or not we should treat this patient, and if so, what approach. And so maybe, would this patient have been considered for radiation at Michigan, Paul?
Either that or observation. I personally will talk about an upcoming case. I would at least push for radiation or advocate for radiation for that subpleural lesion, the 1.2 centimeter. That has a high likelihood of becoming symptomatic either, in the very near future or possibly even now, just based on that location. So even off trial, I'd consider radiation for that lesion.
Yeah,
Dr. Schoenfeld, I feel I need to stand up for the surgeons. Is there, what do you think the surgical perspective would be on this?
Well, again, as not a surgeon, I'll do my best. The surgeons always, I think, as Paul was saying in the beginning, there's some situations where we do, I think really do try to favor surgery. And that's kind of uniform in our tumor boards. And that's when it's a single nodule, especially if we don't have a diagnosis, and it's an easier spot to remove. Because then we answer multiple questions at once. We get a diagnosis, we remove, potentially all the disease we can see, and hopefully patients do well, not just from a tumor perspective, but also from a quality of life perspective in terms of a quick recovery. We think less about surgery the more nodules there are generally, because again, every time we're doing surgery, that's time on one nodule, we're not addressing the other nodule. We also shy away from surgery when we think that the recovery is going to be more challenging. Sometimes these nodules right at the chest wall can be a little bit of an issue because they're right by kind of the lining of the lung, and that can be a little bit riskier in some situations. But again, we would discuss, that's one of the important roles of the tumor board, because we would have a surgeon and a radiologist, and usually multiple surgeons there to discuss kind of the pros and cons for each individual situation.
So there's some questions here about, are you always biopsying these lesions? Did you biopsy both before you would treat? Talk a little bit about that.
I think that's a great question. And in general, the first time lung lesions or bone lesions, anything, appear after that initial diagnosis. You have the initial surgery. After that, there's a new spot that shows up in the lung. It's worth biopsying that to confirm it is, in fact, ACC, and to even consider molecular testing at that point. That being said, when there's subsequent spots that show up, we don't biopsy every single one. And in general, there may even be a lag time from when a spot shows up in the lung to when we finally stick a needle in it. And that's because we wait until it's a safer size. When spots are very, very small, there's a possibility we don't get a sample of it and we just get normal lung and have complications. And so it's a complex decision-making process that the multidisciplinary tumor board always talks about.
Yeah, we don't just talk about, treatment. We often talk about imaging and other management questions too in the tumor board. That's a great point. And so, after treatment for this patient, there were what we call, post-treatment changes. Sometimes right after radiation, it can be challenging to kind of see exactly what's happening because of the changes caused by radiation. But we usually follow these changes over time. And the other lung tumors remain stable. And I will just add that we've done a previous study where we looked at SBRT kind of prospectively, either with or without immune therapy. And we really did show that, radiation is a good local treatment where we give the radiation. It's just a matter of trying to select the patients who would benefit the most from this type of approach. So I think that wraps up my two cases. And so I will stop sharing and turn it over to Paul.
John, a quick question. A couple people are asking SBRT versus proton. Can you comment at all?
Yeah, it's a complicated question that I don't know that I'll have time to do complete justice to. There's multiple different types of radiation that we give that might have some advantages versus another. Photons is the most common type of radiation that we give, and then there's another type, protons. Sometimes we think about protons, especially in the head and neck area, for a variety of reasons. Usually when we're treating metastases in the lung or in some other organs of the body, some centers will think about protons in specialized situations, but usually we do photons because we do a stereotactic body radiotherapy, and because of some of the uncertainty within the air, for physics reasons, we often would not use protons for this type of situation. But it's a good question.
And I would also recommend anybody interested in the SBRT proton conversation, check out our third webinar, because there was a good discussion among docs within that webinar as well. Okay.
So this case that I'm presenting is one that goes over a pattern of years, and we're going to have a repeated discussion about treatment decisions, because I think it gets at many of these points we've been talking about. So this is a 47-year-old gentleman who had newly diagnosed metastatic adenoid cystic carcinoma involving the lung. So to go back, just keep this in perspective, it's August 2016, and this person had flora mouth swelling. The dentist, very full, thought he had an infection. Fortunately, this was biopsy and found to be adenoid cystic carcinoma of the left bottom of the mouth. At that point, just for reasons of staging, CAT scan was done, showed very many, I think it was about 7 pulmonary nodules. The largest was under a centimeter on both sides of the chest, all 5 lobes of the lungs. So it wasn't something we could just remove with surgery. In order to get an accurate biopsy, because they're so small, we couldn't do a CT guided biopsy. We had to do a surgery to remove one of the spots. And in fact, that was shown to be adenoid cystic carcinoma. So the question was how to treat this person with adenoids that was found to have metastatic adenoid cystic carcinoma up front. So we chose to do a primary surgery to remove the cancer at the bottom of the mouth. And also, this person had, when they removed it, had high risk features. We look at it under the microscope. And so the question was, do we do radiation to the mouth afterwards as well? So what would you guys have done at Brigham, out of curiosity?
Yeah, we first and foremost, I think we want to treat patients who are having symptoms to see if we could help. And so in this type of case, there are multiple kind of small lung nodules. Hopefully, those are not growing too quickly. And then there's this kind of a symptomatic area in the floor of the mouth. And so then it's always a question, we're really talking about, in addition to trying to control the disease, what would provide the most, palliative symptomatic benefit. And that's always a discussion with medical oncology, usually, or surgery, about, what are the options in terms of drug treatments, what are the options in terms of surgery. We do often consider radiation for these type of situations, to try to stabilize or shrink the swelling in the floor of the mouth. The issue with radiation in the mouth can be that, we're trying to relieve symptoms, but it's a tough area to give radiation to because it also causes significant symptoms. And so it's always a discussion, to think about, whether or not we should do radiation. So I think, in this type of situation, sometimes doing surgery first would be reasonable to kind of remove the mass because it's on the larger side. And then in patients that have gone through a surgery who have these high risk features in the setting of kind of small lung disease, we would think about them in some way similar to an initial presentation of a patient, and actually talk to the patient about giving radiation after surgery to try to make sure what we call consolidate that local treatment and reduce the risk the tumor came back.
In fact, that's the same thing we did. We have what's adjuvant radiation, as you said, to ensure it doesn't come back to the bottom of the mouth, and followed this person with CAT scans every 6 months. And over time, I have pictures here, and even as a medical oncologist, I think I can do this, and please don't get angry at me, I'm not a radiation oncologist, but we saw a slow increase in these pulmonary nodules. Going up top here, we can see the small lesion right there, that white spot, perhaps that's the most prominent, and that was in 2018. And every scan, every 6 months, it increased by about 2 to 3 millimeters. Each time asymptomatic, and only one was greater than 1 centimeter. And 6 months later, as you can see in 2018, he was known to have a renal mass, but it was hard to say. Couldn't really say if it was cancer or not. And he also was known to have pleural thickening. So that's where the lung joins up with the outer portion. Once again, continue to follow his lung spots. We had this discussion repeatedly. This patient was very well informed and very involved with the research area. And finally, in 2019, we decided to biopsy it, again, just for molecular testing. At that point, we were looking mainly to see if there's anything we could do treatments with. And we found this MIB NF5B fusion, which is very common in ACC. We'll talk about in just a second with some emerging therapeutics that are very promising. And so at this point, slowly increasing in size over time, what would you guys do? I think he had greater than 10 lesions by 2019, multiple lesions over 1.5 to 2 centimeters. Would you have considered treating this as oligo and going for the lesions greater than 1 centimeter, or continued after surveillance given less than 20% growth?
Yeah, this is a tough one. I mean, I think that, typically, historically, 5 lesions have been our cutoff, for what we think of as oligometastases. And even there, I think, once you start getting more than 3, there's some question. Now there's also question, maybe 5 to 10 counts as oligometastases as our radiation techniques improve. But I would say generally when there's more than 5, we don't treat locally unless we're worried about symptoms or growth in that area. And then we would have a discussion, I think, about, given that growth, whether it's time to initiate, systemic treatment.
Perfect. I'm glad we're all on the same page. We didn't commit malpractice. Sure enough, in January 2020, continued to increase in size, asymptomatic. Finally, as we saw, I think we kind of alluded to before, adenoid cystic over time increases in the speed it's growing. I think about this and discuss it with my patients. It's like a stone rolling down the side of a mountain. At first, it's going slowly, but at some point, it starts to speed up quicker and quicker and quicker. And what we saw was that these lesions were getting larger, but he was still asymptomatic. The largest spot in the lung was now 3.5 centimeters. The kidney spot was up to 4 centimeters, so it was getting rather sizable. He was still running a 10K faster than I could, which is saying a lot. This person had an occasional twinge in his side, but it was running a 6 mile, and the twinge could be just sitting around. And here we can see his scans, once again, 2018 versus 2020. To make this confusing, the 2018 scans are at the top and 2020 are at the bottom. And we can see this is the pleural-based nodularity, very similar to the previous case he presented. You can see a little bump here, and a couple years later, this large lesion kind of pushing into the rib here. And similarly, we can see maybe nothing here, maybe a little bit of thickness, and once again, a bump at the rib here on the outside of the lung. Same thing, this little white speck. And now there's a larger white lesion, significantly increased in size over those 2 years. And then along this fissure, the lung here, a little bit of thickness. And now you can see definitely more nodularity bumps there. You can also see a small lesion that was present. You can't really see it now, but several other metastatic cancer spots just in that field of vision alone. So at that point, especially given these spots on the outside of the lung, per our conversation earlier, we already got to it. These were starting to be concerning for either symptoms now or symptoms in the near future. And so, talking to radiation oncology, we pursued radiation to those pleural-based lesions. And that actually did help this patient's twinge, still kept at the 6 minute mile, fortunately. And shortly thereafter, we were getting concerned about the kidney spot, that could actually cause some kidney problems in the future. And so we performed radiation to the kidney spot, and eventually to a lesion in the lungs too. But despite all of that, about 6 months later, we performed scans and we could see that it was once again picking up in size. Compared to 6 months prior, went from 2.2 centimeters to 3.1, 3 centimeters to 3.6. So greater than 20% growth within 6 months, despite our local therapies. Still active, but occasional pulling sensation.
Can I ask a quick question before you move on?
Yeah.
John, they've irradiated at several sites. Could you go back if a new lesion showed up in a similar location? Can you re-irradiate that site, or does that change how you might do a treatment?
That's a great question. We often try to avoid giving radiation to the same site. There's some side effects of radiation that can be cumulative depending on the total dose that's given. But it varies. I mean, it depends on the timing when the radiation was given, the dose of radiation, the situation. So I would say that's a really individualized discussion. But in general, a prior course of radiation to that same area, we can give radiation to other areas, but prior radiation to one area does make the discussion about future radiation to that same area more complicated.
So once again, pictures here to kind of put perspective this time. This is out of order to like we do in tumor boards. So actually 2020 is over here, 2021 is over here to keep us out of just paying attention. We can see that the lesions are increasing in size even within the matter of a year, almost double. Once again, here's another lesion slowly increasing in size. And also we saw new lesions popping up. So what's the point of this story? We went from 2016 with the initial diagnosis of metastatic adenoid cystic. He eventually got radiation almost 4 years later. And finally, because of this increased growth, new lesions, that's when we finally started systemic therapy. So here's a person, asymptomatic, and we were able to just watch for 4 years with nothing at all and no impairment in the patient's quality of life. So I think this points to the fact of the multidisciplinary discussion and when to finally choose those tricks out of our belt. And it's also a complex discussion with our patients. And, in the end of the day, it's you all are very, the ultimate decision makers here. But I think this points the complexity around to some of these things. And I think it gets to the question, too, about when, as a medical oncologist, do we reach for a systemic therapy? think that goes into here. Yep. And so it's hard given the variable history of adenoid cystic cancer, how these grow, and every single cancer is different. What we're realizing more and more is that we wait until it's picked up that disease trajectory, when it's growing faster and faster, at least increasing in size by 20% within 6 to 12 months, as well as being at least 2 centimeters in multiple spots. We can't just radiate those, 2 spots that John's talked about. It's something that's many, many spots, and it's growing quicker. That's when we start talking about, a systemic therapy. And our go-to, if available, is a clinical trial, because we really think clinical trials offer us a way to move the field forward and offer us something better than what we currently have. Right now, targeted therapies, they're called like lenvatinib, axitinib, all these what's called a VEGF inhibitor are typically our go-to based on some clinical trials. It gets kind of complicated here, but I have some of the information shown here showing that we're making ground, but still have some room to grow. What we see with a lot of these drugs, here are 2 typical agents, axitinib and lenvatinib, is that tumors very rarely shrink. In fact, no growth is a very good thing. We're just looking to stabilize the cancer. However, what we're hoping to do is just stabilize that growth for some period. On average, with our oral pills, with some of our agents, it stabilizes it for about 6 months to about a year. And then we just look for that next, the next tool in our belt. Immunotherapy has been tested, including by the Harvard group, and unfortunately, it hasn't been as effective as other head and neck cancers, but we're looking at different combinations there. But so far, it hasn't really made the change that we would hope for. Currently, some areas that are clinical trials are evolving. There's directed clinical trials for this MIB fusion that I mentioned before. Adenoid cystic, when we started doing molecular testing, we thought it'd be like lung cancer or melanoma, where there's a very specific mutation. We could use a pill and it would reverse the cancer and get rid of it right away. Unfortunately, it hasn't been that easy, but there's now that fusion, about 80% of patients, which there's several companies coming up with a drug that might be able to at least stabilize the growth in those patients. And those studies are ongoing. And so hopefully within the next couple of years, we can get a sense of how those targeted therapies will work. There's also some next generation kind of chemotherapy type drugs that are IV, called antibody drug conjugates, the idea of kind of depositing chemo just inside the adenoid cystic cancer cells. And I think those are very promising in the next couple of years. But once again, these are all clinical trials. And for the first time ever, we have, several clinical trials in this area. So it's an exciting time to be moving the field forward. So I think that's it for that case. We have one more, but I think in the interest of time, we could stop there if you want, Jeff. It's up to you.
Maybe you could just do an expedited version. And
okay. This one's a pretty quick case. So this 53-year-old lady with metastatic adenoid cystic carcinoma, originally diagnosed 4 years ago with intermediate grade. She was treated with surgery, followed by radiation, and had no cancer for 3 years. And then unfortunately, the cancer came back in her left neck, her lungs, and actually kind of concerning for her liver, couldn't say for sure. Asymptomatic, it was all quite small, below a centimeter, even hard to tell. She decided she was very active, works full-time, didn't want radiation. We talked to her actually about treating with radiation to all the spots they saw. And unfortunately, 3 months later, there was new spots in the lungs. There was a liver spot that was now up to 6.1 centimeters, so very large. So at that point, she enrolled onto a clinical trial of a targeted drug we had at our institution as well as other places. And she had a great response. Her lung spots all shrank. She was doing very, very well, and her liver spots stopped growing. And the issue is that about a year into this, her lung spots, although stable, finally her liver started to grow. It went from 6.1, 6.5 centimeters to up to 8 centimeters. And here's what a picture of that would look like. Here's before the clinical trial, and here's now a year later. And per the clinical trial, there's very tight rules what you do under certain circumstances. She would have to come off the clinical trial. But now we're having the question, everything's stable except for this one liver lesion. So what do we do? And so throw this to you. If this was in your clinic, what would you do?
Yeah, again, with one dominant lesion. So sometimes there's oligometastases, as we talked about. There's another concept that we're kind of, or another scenario, which is oligoprogression, which is patients that are benefiting to, whatever drug usually that they're on, and then have one area that's causing problems. And so we do try to target that area. The liver's a hard area for, what I do, radiation often, because, you want to preserve the liver. For smaller lesions, we often think about SBRT. That's most common for gastrointestinal tumors, but, we do sometimes do ablations and SBRT for adenoid cystic carcinoma as well. When lesions typically grow this size, we often consider other options because we can't do SBRT usually for lesions this size.
John, what's the size in a small? Like, what do you mean by small?
Yeah, it's usually, it depends on to be honest, it depends on the normal liver. This is complicated because it's away from, it's kind of at the side of the liver, but it's also close to the stomach. And so it depends on the other organs that it's close to. But usually once we start to, 5 centimeters or larger in most locations is not really appropriate for SBRT. Even once, in many locations when it's larger than about 3 centimeters, 3 to 5 centimeters, we really start kind of, thinking about other options.
Thank you.
And in this case, as you were saying, was progressing in a single lesion. All the others were doing quite well. She wanted some time off therapy. And so we decided to treat this aggressively with radiation. There's actually a clinical trial that's available here regarding treatment of liver lesions. And so they treated it quite aggressively with different types of radiation in combination, which I won't go into because I don't presume to step on your toes there with all the types of radiation. But the result here was that she was able to handle that spot well, developed result or no symptoms there, and had no therapy for some time.
Okay, and I think this concludes the case series portion. We want to thank Dr. Schoenfeld, Dr. Swiecicki for their time, for sharing their expertise. I think, the chat was just constant with questions. And so, sharing these cases and sort of talking through the nuances here, I know is going to be helpful to the people that attended, the webinar today, but also, this will be posted on ACCRF's website. And I know, folks will continue to look at that. So thank you so much for your time today. And you can.
Someone else joined the tumor board. Sorry.
There you go. So you guys can turn off your microphone and your video now. And thank you again.
Thank you.
Okay, so I'm going to wrap it up because we're 1 minute from the hour. I think we learned today, right, all about multidisciplinary tumor boards and how they're used to develop a treatment plan for, both in the primary, which we didn't talk about today, but recurrent metastatic ACC patients. We talked about a variety of different treatment options that, a patient might consider: watchful waiting, surgery, radiation, or other types of ablation, which we didn't go into, today, but things like cryo or microwave ablation, and systemic therapies. And, figuring out what is the right treatment is really based on a variety of different factors. So the number of lesions, the location of the lesions, how fast they're growing over time, as well as, which treatments did the patient receive prior, as well as their overall health, which we kind of didn't have time to focus on. But, how well are the patients doing? And, do they prefer maybe to have one side effect over another? Or maybe prefer is not the right way, but would they want to handle one over the other? And then I think it's important to really hammer home that, routine CT scans and sometimes MRI, we talked about CT also in the abdomen, they're really recommended for all ACC patients. And so we talked about this in the chat, but not just patients where their primaries are in the salivary gland, but other body sites, lacrimal gland, breast. All folks should be having routine screens to monitor for recurrences, and then also to monitor how fast they're growing, because I think you can appreciate from this conversation that growth over time and the location of the lesions really impact how the physicians will decide on a treatment plan. Next slide. Okay, so how can you stay informed? I think at the top here, you can see our website. A lot of the information that we talked about is you can also find resources and materials on the website. Please sign up for our quarterly newsletter. Through that, you'll find out, new grants that we funded, new publications, and then changes in trials, things that have opened, closed, and sites where they're recruiting, as well as, different events that, may offer ways to connect with other patients and to fundraise. You can always email info@accrf.org with questions or ideas, and that comes right to all of the ACCRF staff that were on here today. And we also have our Facebook group, which we use to really share information there. And then, see sort of down below again is just sort of how can you connect? What are the resources we have? And we would like to hear from you. If you have ideas for other webinar topics, we'd love to hear it. So thank you again for everybody who has attended today. We appreciate your time, and we look forward to connecting with you in the future.